Hey, I'm Sarah Smith, family doctor, clinical day advisor, and the chatting coach. Welcome back to Sustainable Clinical Medicine podcast, where we're going to be interviewing peers or world experts who can help us think about our clinical day in a way that is more sustainable and create time for our lives outside of medicine. Hello and welcome, everybody. Today we have with us Dr. Nondumiso Makhunga-Stevenson. It is so lovely to have you with us. Thank you for coming.
Thank you, Dr. Sarah, and wonderful to be here with you. And I'm excited for the conversation we're going to have.
Totally. Tell us a little bit about you.
My name is Nondumiso Makhunga-Stevenson. I am from South Africa. I am a medical doctor. I was born and raised and also trained in South Africa as a doctor. My journey's been quite interesting. Looking back, I've had more than 25 years now, I believe, as a doctor, or almost 25 years as a doctor. And I have seen and worked in so many different parts of the healthcare ecosystem. And so it's been a wonderful journey. I think, like many doctors who are considered late career doctors or mid to late career doctors, there are ups and downs, but if I had to do it again, I would still choose medicine, and especially with everything that I have learned. I'm currently, though, in the USA now. I moved here in 2024 to join my husband, and that was the only reason I moved over here. And that warranted a change also in my professional direction. And just before I left South Africa, I discovered coaching. And I'm sure we'll get to how and why. But like many other doctors, I found myself benefiting greatly from coaching and realizing that there are so many doctors who are also in the same position as me, who are experiencing the same frustrations or challenges that could benefit from coaching. And so for the past just over 2.5 years now, I've been coaching full-time based here in the US. Yeah, so that's a little
There we
bit
go.
about me.
Yeah. Tell us about your medical career. What were you doing in South Africa?
Yeah, so I started like so many people in the clinical space, and looking back, I think there was very little in those days. There were very few opportunities outside of clinical medicine. And after a short stint of locuming in the UK, I was quite intrigued by public health and health systems in general. That was my first exposure to the NHS. And that kind of took me into that particular space. So I worked, in fact, my first leadership role was in a public hospital, Chris Hani Baragwanath Hospital, which is one of the biggest hospitals. I think now it's probably the third largest hospital in the Southern Hemisphere. At the time, it was much higher than that. But a really big and sprawling entity of a hospital, just physically in terms of the buildings, but also the complexities of hospital management. And so I was thrown in the deep end, to be frank with you. I was just less than 5 years out of my community service. And I was assigned because my manager he was aware that I didn't have much experience. So he assigned me the smallest department, which had around, at that time, around 200 beds, which was the pediatrics department, including the neonatal ICU. So a very complex department. But what I learned from that experience, I think there were so many lessons that I've taken into also my coaching practice, and especially around the transition from clinical roles into non-clinical roles or from clinical roles into leadership positions. So I found myself really in real life managing and leading and interacting with people that were not clinicians, right? So working with people from the quality improvement and quality departments, working with procurement. I got much closer to understanding the functions of the financial teams, of human resources teams, public relations, all of those teams, something as we're not trained in medical school. So yeah, it was a baptism of fire, if I can put it that way. But there were many lessons that over the years, I think I learned from that. And from there, I think I moved around between nonprofit organizations, especially as you know, in South Africa, we had many programs around HIV and other communicable diseases. So I headed a lot of those programs as project director and also as a country director at a time. Some of the programs that I led were local programs and others were regional programs. But my last stint was where I found coaching, and that was in the pharmaceutical sector, which is a very interesting sector because for some reason I had always been attracted to it. It just looked like a place where I could challenge myself, something that's really far removed from clinical medicine. But my first year in pharma was very challenging for me. From the outside, I think it didn't look that way from the outside. But from the inside, I was really battling with so many, with the transition into the pharmaceutical sector. And eventually my sister, who I was watching on the sidelines, her career was just thriving. She was just moving like at lightning speed. And I confided and I said, you know what, I think I made a mistake here. I'm not sure if I want to do this anymore. This is supposed to be my dream job and I'm just not loving this. And she said, after listening to me, she said, I think you need a coach. And I was like, okay, that's fine. Let me see what's the worst that could happen. And I found a coach. And what I can share with you, and I think, of course, you're a coach and you speak to coach, you know the impact of that collaboration and somebody holding space for you to really think through what you want for yourself and importantly, who you are and who you want to be in a particular situation. And so that's what the coach did for me. And I want to share with you, Sarah, that within a few months, I was promoted into a global role, which not only was just about the promotion, but it was also a role that really aligned with my strengths, with my passions, with my mission as a doctor. Now, nothing had changed in the organization, absolutely nothing. But I don't believe that had I not met with a coach or had the support of a coach, I would have been able to really see that transformation as rapidly as I did. More than anything, it was not that I did anything exceptional. I did not get a new qualification or anything like that. What I was able to do was to move forward. And that's really the beauty of coaching. So following that, I started meeting with a lot of colleagues as well, and they were also watching me. And I think I also gave off very confident energy. Not that this job was less stressful. Every job is very stressful. And as we talked, it became clear to me that there are many of us who had been through this, just silently and quietly struggling with many different issues around leadership in the way that I had. And so that's when I decided, I think I need to pass it forward and focus really on working with other doctors because the issues that we're struggling with, I realized were part of what we had to unlearn from medical school. There are many things that we learn, which are good, of course, but there are many things also that if we do not have the understanding or if we lack awareness, we're not going to be able to move past. And so that began my coaching journey, which coincided also with my move to the US, where I found, wow, this is a whole big pool of people. Unlike in South Africa, it was just fewer people who were coaches. But I found in the US, I was so amazed at this coaching thing is a thing here. So that really began my journey, and it's been very exciting. So I'll stop there because I know I can talk a lot about my.
I had some questions. You said that the pharmaceutical move was your dream career. What does it look like to be working? What was your vision for what would a day in the life of working in this position look like?
So I had joined the pharmaceutical company as a medical advisor in medical affairs. And a day in the life included primarily supporting the commercialization of the pharmaceutical products or drugs. Now, I can say this today because that is the insight that I had then. When I joined the pharmaceutical industry, I did not have that understanding. In my mind, I don't know what I thought was going to happen. I had seen doctors in pharma coming and helping us with CME trainings on particular disease conditions. And then I also, of course, was aware of sales reps. And that's really as much as I understood. It just looked like something that I wanted to challenge myself with. The shift that I had to make was that I had to apply my knowledge differently, and that in fact this was a commercial entity. Having spent a lot of time in mission-driven nonprofit organizations, you are not really driven by constraints around budget, regulations. Of course, there are some regulation, but if the projects, for example, that I was working on were about making HIV testing accessible, you would do everything to use every single dime of that budget to reach people so that they can have access to services or to products. So moving into the pharmaceutical sector, I had to really make peace with what my mission looks like and how does it translate in a for-profit environment. So there was a lot of friction that I experienced, and I think many doctors who move into for-profit organizations also struggle with that. My belief is that if we could, and I don't know if you agree with me, but I believe that if doctors could serve every single person every single day, and that's all we do, that's what we would do, right? If budget was not an issue, that's who we are. I think that's what I believe. Many of us are called to this work because we want to serve. So the friction for me came in terms of how then do I serve, right? And I had to make peace with the fact that medication and my journey in pharma helped me really understand that the money that gets invested in drug development is not insignificant. And so in my mind, drugs should be much lower. I just had no understanding before. Why are drugs so expensive and so forth? Some of the things were commercial decisions that you have to be involved in. And so that was really where I experienced the friction. And I had to really take a look at what it is within the organization that I'm contributing, and also the bigger picture. Is it really true that I cannot still be of service? Or is it really true that working in the pharmaceutical sector is not aligned or is misaligned with the values that I hold as a doctor? So those were all the things that I had to work through. And once I was able to really reframe that in my mind, then I could, as I said to you, come to that understanding that my role is to help the organization bring these life-saving drugs in many cases to the market. And that's how, and I had a role in terms of contributing to that. So yeah, it was a steep learning curve, but yeah, I came out of it, I think, really understanding myself a little bit better and also understanding the sector a bit better.
Yeah, that's a big jump to go from not-for-profit, where you're working on shoestring budgets, to help as many people as you can, to whatever that looks like. You said dispersing testing or dispersing medication, into almost the polar opposite of I'm the big pharma now, and these are the medications, this is the price, these are the things we're developing, this is what we want to disperse out into these countries. That I can see how there would be that shift in, oh boy, is this still aligned with my values?
Mhm,
Yeah,
definitely.
yeah. Interesting to see how you used to coach for that. We know that coaching in commercial sectors has been around for a long time. What industry was your sister in that she recognized that a coach might help you with this career transition and with your possible misalignment of how you're thinking about this new role and the effect it might have on the people it's trying to look after? What is she doing and how did she know about coaching?
Yeah. So my sister is actually in the music industry. She's in publishing, music publishing. And this was as part of her transition into a new industry. She had been working in a different part of the music sector and was moving to publishing. And I think for her, it was less of trying to focus on what do I do next, and it was more around performance and so forth. It was somebody in a senior leadership role. But you, as you said, for me, coaching is universal. I am trained as I'm accredited rather and credentialed as an ICF PCC coach. So I have found that the principles are the same irrespective of the industry. For the most
Mhm.
part, I do coach physicians and healthcare workers. But for my pro bono work, I actually enjoy coaching outside of the health sector. So I've coached people from sales, a career from sales. I've coached people from marketing, legal departments, various careers, professionals. And I found that as equally rewarding. At the end of the day, and this is perhaps we'll get to it later as I share my approach, but my approach is really rooted, or is it really at the intersection of Ubuntu and professional identity formation, particularly as it relates to leadership. As in coaching, we don't coach the problem, we coach the person, which means that coaching is very portable in that sense. Whether it is, and I coach people from all over the world, whether it's a physician from South Africa, from Rwanda, from Kenya, from Ecuador, from Brazil, from United States, from Canada, from the Caribbean, if you really follow the structure and the principle of coaching the person, then the the transformation is just as equally significant because the focus is really on the individual or the context. I think what is different about coaching physicians is that I have obviously a significant understanding of why things are the way that they
Mhm.
are based on how we've been trained, how we've been socialized, which to my surprise, I also discovered it seems to be the same actually, whether somebody studied in South Africa or Kenya or Rwanda or any other part of the world or Cuba. It seems that our training produces a certain type of identity. And that identity, I don't think it's inappropriate per se for the type of work that we do, but it does lend itself to other challenges that are amenable to coaching.
Let's hear about some of those challenges, some of the work that you do in the healthcare and physician space, because I think that will help us understand what is it about us and the way we're trained, the way we're showing up? And that could be creating tension, troubles, difficulties that can then be improved or helped or assisted.
So I'll use perhaps as we go even examples of myself where I how our identity is formed. So we have we are trained to adopt certain values and norms that are in line with the expectations of the profession. And some of those values include, for example, putting the work first, right?
Hmm.
Prioritizing the patient. And not that's a terrible thing to do, of course, but it often, when not done or supported, becomes challenging because it can lead to burnout, right? The other thing that I think is inculcated in us is responsibility and accountability.
Hmm.
Again, that is not a terrible thing. If I see a patient, I'm responsible, I'm legally responsible for that patient. But there are sometimes certain challenges in the transition from clinician, particularly to leader, where how that looks is becomes challenging because that's where people become they become reluctant to delegate, for example, right? So that's kind of one of the ways that happens. We often look at our worth as how much work can I do, right? As opposed to, especially when you're a leader, is how much work can the team do. So those are the
Hmm.
sort of the two areas that I've noticed as clinicians make it quite challenging for us to move to leadership roles. And then the last thing that I can share also is related to that is, I would say, external validation, right? Where we wait for certain standards or certifications to validate our competence. So, in a way, we are always trying to prove our competence. And I see that translating, yes, in leadership, because that's also my area, but I do also coach people in who are challenged with productivity, especially around charting. And I know this is also your area. Often the relationship with the chart is not about the complexity of the chart. I think, and please do correct me if I'm wrong, I think this is really your area of expertise, but the process of charting itself is not necessarily difficult for the most part. It is writing the notes, but the behavioral issues around that are sometimes what weigh down on us. Notwithstanding, there are also structural issues, but in the absence of those, you find that people may be tempted or they may fall into the trap of trying to prove their competence in the chart. And
Hmm.
that's not where the competence should be, but for various reasons. And I don't think it's a conscious thing that people do. But I've noticed as throughout coaching and people who are struggling with the chart, it's beyond what is required for continuity of care. Yes, the chart is the motivation for writing is not necessarily in service of that requirement. It's in service of myself. I'm proving something to myself. I'm proving something to my supervisor that I really am very competent in this work. So yeah, those are just some of the examples where I see our training and our professional identity also tripping us up in some ways.
Yeah, I do see that definitely for a good number of physicians who are struggling in the area of note completion. There could be something that holds them back, such as, I don't know all the answers yet because I'm waiting on test results, or I've only met this person once, or that was a really complicated story and I don't know what's actually going on yet. So I need to pause and await further information before I can get this note done. Or like you said, and I had this example recently, day one of working, they were told off for many aspects of their note taking. You didn't spell that right. You didn't put a capital letter there where you needed to put a capital letter. We include it this way in this specialty. And that had just flowed on to this decades later, still held accountable to that person who'd rung them that day to report on the adequacy of their notes. And I know in my own personal journey, when I was thinking about who was I thinking about when I thought about who was going to be reading my notes and judging me, and when I realized who that person was, I decided that was forevermore not going to be somebody who stole more of my time and my life because they weren't somebody that I respected or liked even. And that was a made a huge difference in abandoning that level of expectation, like you said, above and beyond what's required for continuity, informational continuity and completion. And it's really holding us into a space that really no one else is looking at the note for. Or you're the expert in your note. You know what needs to be in there for continuity, for medico legal, for insurance, and then the beyond and beyond. Yeah, that identification, you're spot on there. That for a lot of physicians, that piece just holds them trapped in this cycle.
It manifests in so many ways, even my own experience. And it's since I have started working with clients and supporting them through coaching and documentation that I see some of the times where I was fighting battles through documentation. For example, when I worked in one organization, we used to do a lot of travel, and part of it meant reconciling your travel and so forth. Now, that's a process that doesn't take long. It's a 30-minute thing to do. You say where you traveled, put the receipts, and you upload them and so forth. And I got busy, and only to be reminded, and it was just a routine reminder about it. But in hindsight, I realized that I took that so personally that because what it was, I felt challenged about my competence at that point. It was not you are late. It wasn't that late. But this fight went on and on. I felt quite offended. And invariably, I got into big trouble because of that. And I had no option but to complete it. And as I said, it didn't even take 30 minutes to do. But it's only now I realized that the delay in doing that was not at all of the complexity. It was very simplest thing that I could have done. It was somebody sent an email and said, "Oh, don't forget you because it's late," and that was a challenge to me personally and my competence. So yeah, those are the things that I think where coaching becomes of huge benefit because we have those blind spots, we have those responses, and when somebody is there and building a safe environment and probing you, then you can really start to identify where those obstacles are, whether it is, as you say, fear of judgment or fear of litigation, whatever it might be, then you can really at least have some insight and then you're able to work through it.
Yeah. I liked what you said about the transition from physician working with your patients to leader, and that what can I do and your limitations personally versus what can we do. And I think that is a skill as we move to more team-based care in many areas because there is limits to what one person can do, as there should be. And what can we do is a very different question. Even if it's just what can we do as our small team working with this patient group, not leading the whole organization, but what can I do within my space where what can we do within this space? It's a very different question. And it's a skill set that we may not have been given. Certainly, we work together in little teams in all sorts of places. So we have multidisciplinary team meetings, or we have emergency departments, and you're on the trauma team for the day, or you're in your diabetic clinic for the day. But a lot of doctors are working in isolation. They're just seeing what they can do, and their patients are coming in and they are responsible for that interaction versus what can we do. It's a very different way of approaching it. And you're right that that doctor piece, that medical training piece that says you are responsible, you're legally responsible for the outcome of this patient's care based on what you personally know and do and learn about and implement for this patient does not translate well to what can we do, because now we're micromanaging everybody to make sure we get, or we're giving of ourselves so much, or we're burning ourselves out within a team because we still hold that heavy responsibility.
Definitely. And as I shared earlier, part of my work is rooted in the African philosophy called Ubuntu. Ubuntu is a relational philosophy. So it's been widely translated to I am because we are. And one of the things that I've dedicated myself to is really unpacking what that looks like in leadership. There are many people who have written about it in leadership, but it is really a mindset. It is an unlearning. When you are in a clinical space, as I'm sure you would agree, and as we've said already, personal responsibility and accountability is very important. When you transition to leadership, it's also equally important, but it looks different. It looks different because the responsibilities are different. So one has to really rise above that. So if you approach it from that perspective, and this is the lens through which I see leadership, through that Ubuntu lens, and as I said, with the intersection of professional identity formation, what it says is that my success as a leader is not necessarily dependent, it's actually connected to the success of the team and all of us as team members. What that also means is that the team has a shared responsibility to meeting the goals of the team or of the organization. And my growth as a leader, how I'm constituted, how my leadership develops and grows, is in fact dependent on the team that I lead, and vice versa. So I think once that mindset is adopted, then it really becomes, how do I delegate effectively? I recently wrote an opinion piece on with one of my mentors who's well published on Ubuntu and team leadership and around the leader as coach, right? Because as coach, what you do is you also help people in a way that is not necessarily instructive, but that can also empower them. So there is still, as a coach, you are still an accountability partner. You do hold the coachee accountable. So these are the things that I'm passionate about. I spend a lot of time literally just thinking about these things and how they could essentially transform the way that physicians lead. And I think for me, when I coach the people through that or have conversations with physicians around Ubuntu, it's not a hard sell. We started off our talk talking about the type of person that is drawn to the work that we do. These are people who want to help, who want to serve, who want connection. They want connection with patients, they want connection with each other, they want connection with community. So it's something that I think is very easy to see and adopt, that in fact, a lot of the suffering that we have currently as doctors is because of disconnection. The disconnection is not necessarily because of things that are within our control. I think everywhere the health system can present so many challenges for us that make that connection and time for connection very difficult. And that's who many of us are. We're just passionate about helping people and being with people. So even in leadership, that yearning for connection is very relevant, and I believe it can be harnessed together with how we've been trained in order to become effective as leaders.
Love that. How do people find you if they're wanting to connect with you?
Yes, my website is www.ubuntu, ubuntu, doctorcoaching.com. So www.ubuntu.doctorcoaching.com. And they can also email me. It's Dr. Nondumiso at ubuntu.doctorcoaching.com.
Love that. And final words for someone listening who is feeling that pull or stretch. Maybe they've thought about a leadership role, or they're just pulled or stretched in the environment that they are right now. What's something that we can leave with them for today?
Yeah, I think the overarching message, in line with especially the amazing work that you are doing, and the message also that you are propagating, Dr. Sarah, is around sustainability, and that one lens of looking at sustainability, and I know we want to work forever as doctors, but sustainability can come from, I want to say, relational wholeness. It is not only the mindset, but the practices that we adopt. It's not only about the protecting our time, but it's also about restoring the wholeness to relationship, whether it is with patients, with colleagues, and importantly, restoring the relationship with ourselves. So it is possible to evolve with our careers and adapt to the challenges. Medicine is very dynamic, but at the core of it, having and prioritizing wholeness and relational wholeness is one of the ways that we can ensure that we have sustainable careers.
I love that. Thank you so much. And thank you for this conversation.
Thank you for the invitation, Dr. Sarah. I really appreciate it.
All right. And you all have a great rest of your week. Thanks for listening.
Thank you. Same to you.
Hey, if you found this podcast episode helpful, I would encourage you to like and subscribe. Every time you do, you help a colleague or friend find our podcast, and it can help them too. Don't forget to share it along with your friends. If you're looking for extra help, don't forget we have Charting Champions for physicians and Smarter Charting for nurse practitioners and other clinicians to help you get home with your work done. We are helping you create sustainable clinical medicine. Thanks for listening.